thank you very much for letting me talk a few minutes about this new study that I have been leading. It's a cost of illness study in Europe that is probably the biggest study that has ever been done. 17,000 patients answered our questionnaire, 14 pages questionnaire. So here goes a big thank to all the patients who did that. And we had 16 countries and Poland was part of it. The findings in the study, some of it is new, some of it is not new. We did know that EDSS, as it gets worse, drives quality of life downwards and costs upwards. We have these two opposing curves where quality of life decreases and costs go up. What that does tell an economist is that we should put all efforts on treating patients early so that we can keep them early in the disease, so the progression is slower. So it takes longer to go to EDSS 4 or 6 or 8. So that is the conclusion we can take from these data. The findings have been interesting insofar that whenever you talk about the disease, it doesn't matter one bit whether you live in Moscow or in Sicily. It looks exactly the same. Patients answer in the same way how they are affected by the disease. One is ambulation, clearly, but then we have fatigue. 97% of patients complain that they are very, very fatigued. 70% of patients consider themselves a bit handicapped in terms of cognition. They take longer to concentrate, they take longer to read, they have more difficulties to absorb things. So this obviously has an enormous effect on work. And we have shown also that these two factors do affect how well and how much patients can work. Patients themselves tell us that fatigue is the biggest problem at work. Ambulation is much easier to cope with because things can be done, jobs can be changed, but this enormous fatigue is really bothersome for patients. So to me, the big surprise in this study has been that fatigue is not related to EDSS. Fatigue is across the board at all levels of EDSS, almost at the same level. The same for cognition. They start early. The issues with cognition start early. They're the same in late disease, so not related to EDSS. When we look at the costs, we have the participation in jobs, being able to work is very much related to EDSS. The higher the EDSS, the fewer patients are able to work. Consumption in the healthcare system, on the other hand, is much more related to what a country has, the number of neurologists, are they MS nurses, are they physiotherapists that help the patient. So it's more to do with the local national organization than with the disease itself. Costs clearly go up as EDSS goes up. In the overall study, they go up about 5 times between an EDSS 0-1-2 and an EDSS 8-9. In Poland, it's a little bit flatter. It's about double or 2.5 times goes up. And the reason is that Poland is one of the countries in the study that offers less social support to patients from the system than, for instance, rich countries like Sweden or Switzerland, which do much more, which means families have to do much, much more work in Poland than, for instance, in Switzerland, because there is nobody else to help these patients. Whenever we look at this study, if you want to look up the papers, do remember that everything in this disease is driven by the severity of the disease, which is also related to age. The older the patient, usually the more severe the disease. So do not compare between countries. Do not compare a patient with an EDSS 7 to a patient with EDSS 2. You have to look at the groups of severity by itself, particularly when it concerns costs. For fatigue, you can go across the board.